Thank you. Please continue to eat your lunches, but quietly. For those of you who don't know me, I'm George Benjamin. I'm over at the American Public Health Association. And we've got just an absolutely marvelous speaker for you for lunch today. She's going to talk a bit about advocacy. It's Dr. Pernell, who's at the NAACP and does the health equity work there. Just remind you that advocacy is just the concept of engaging policymakers, the public, other organizations in a way to try to help move an agenda. It can include lobbying. And that's one of the challenges that we have with those of us in the nonprofit world, because we always have to, the amount of actual lobbying we can do is limited by law, by tax law. But it also includes the opportunity to educate, particularly educating elected officials. So when we want to do lobbying, but we don't want to call it lobbying, we call it educating. But it truly is trying to basically persuade people of your position and try to get them on board. And at the end of the day, you know, you're never going to move the people on the far right on an issue or the far left on the issue. But your idea when you're doing advocacy is to try to get people to move those people in the center, who are usually not real clear about what they want to move to your position. So without further ado, I'm going to ask Dr. Pernell to come up and give us her presentation.
Good afternoon, good people. I'm from the church, so I'm using equal seats back to me. So at one point I need a call and response.
You need a mic to go through.
Am I on?
Not working.
No, I'm supposed to be. See, I already worked that out. I don't like to stand still either. But it's a pleasure to be with all of you today, and I'm grateful to the leadership of the NMA, both Dr. King and the incoming President-elect, Dr. Mitchell, and of course, my dear co-member, Dr. Benjamin, for the introduction. I'm a public health and preventive medicine physician by training. Actually sit on the board of the American College of Preventive Medicine. So public health action, health equity, health justice, racial justice, there's a lot where my practice has really been rooted for the past decade or so in coming out of the hospital sector into the NAACP has been a bit of a gear shift for me, but for such a time as now. Amen. See, I got into a lot of trouble when I was in the hospital sector because I couldn't keep my space or position as others wanted me to, because I found myself in the awesome position for my community and for Black people and for other historically excluded groups to be able to speak truth to power and to speak to the then Trump administration about its failures around the COVID-19 pandemic, which not only decimated my community, but was an impact on my family personally. I lost my father. He died at one hospital while I was working at another. My sister was a long COVID survivor. I lost 2 cousins to COVID, right? So I was deep in the muck, deep in the mire, deep in the trenches of that work. But I learned something about advocacy, and since this is what the focus will be today, I learned something that I had already mastered, if you will, by being an advocate for my parents. Mm-hmm. And I learned more about who we are as a nation. And we all know disparities. I don't need to teach that to you. We all understand what are the root inequities driving those disparities, but I learned more about it being a patient myself, and then being an advocate for my parents, and then being an advocate for my community during the pandemic. So at the NAACP, I've really had this opportunity to imagine, if you will, alongside some others deep in the trenches and alongside all of you, how we begin to advance, drive, achieve health equity. And I was having this existential conversation before coming into this role. What was the best way to do that? So this is a bit of an experiment for me, right, being at the NAACP, and one that I'm loving so far. But the thing that has really grabbed hold of my heart, my spirit, my soul, and my person is fight or flight. And I'll give you a little bit additional detail about why I start there with fight or flight, without naming all of our funders or sponsors or collaborators. But fight or flight, that's the conversation of the day. Who's going to hold ground versus who's going to cede ground? Down to language. Down to frames. When we know the truth of the matter, but can we speak the truth of the matter? And then, I fancy myself a good troublemaker. So from chaos to clarity, and you all know where I'm pulling from chaos. Learning objectives for today. At one point, I said I want to put one sentence on this slide, but I said, let me play this thing. Let me play right. And I put out the three learning objectives. Nothing here is rocket science. You might hear something you haven't heard before. You won't know the intricacies of the work that we're doing at the NAACP, so I will share those with you. But this is really an opportunity to build with one another, to have a conversation, and for this conversation to then begin to ripple out into a wider practice space, to ripple out into the context, the social and cultural and political and economic context that we all live, work, play, pray, breathe, and age in. So we're going to talk about public health and health equity under the current political determinants. Describe an approach. Now this term may be new for you. We will define it. This comes from my days in the labor management space, working with organizational development consultants, a VUCA environment, right? How do you approach issue and policy advocacy basically when all heaven has broken loose? Okay, let's keep it clean. And when you don't necessarily know what the goal is because the goalpost continues to move because either the opponent on the other end doesn't play according to the same playbook as you, or there are just so many different opponents that you're not sure where incoming is coming from and how you need to be able to articulate, navigate, and be flexible and agile, if you will. And finally, just to talk some heart work, right? HEART, talk core values that are needed at this time to navigate this. This is one of the best graphics that I've ever come across when helping people to understand the differences between inequality, equality, equity, and justice. I'll take you back to my days as a C-suite executive at a safety net hospital in Jersey, and I sat across the table in my office from a counterpoint, and he told me basically he did not believe in equity. This pre-administration hadn't even happened yet. I don't believe in that. He's an executive at a safety net hospital. My job is to make sure health equity is a part of the operational bottom line, and he sits across from me and he tells me, I don't believe in that. It should just be about equality. People don't care what the color of their doctor is what he was saying to me. A black African-American, one of whose parents grew up in the Jim Crow South. And had it not been for the know-all that I have about healthcare, they would have died even sooner than when they died. People don't care what the color of their physician is. Dr. Chris. People just want a good doctor. They just want a quality doctor. Right? And so I'm having this conversation with him about the differences between equality and equity and how we can't even get to equality when the playing field is not fair. Right? And so basically this is what this graphic shows. The tree is bent. The tree is skewed. And because the tree is bent and skewed, there is a difference in the fruit on either side of the tree. Does fruit grow in all places? Yes. But does it grow in the same abundance? No. Does it grow in the same quality? No. Okay? And so then if you want to move from, equality to equity, then what do you need to do? We get out our tools. I'm a prevention doctor. I'm always talking about toolkits. Let me go into my toolkits. Let's pull out our tools, right? So we pull out these custom tools that meet the explicit needs of the population or the group or the communities that we're working with. We want to have a historical understanding of the forces and the factors that contribute to the outcomes that we see, but the tree is still big. Liberation. And there's still a difference in the amount of fruit on the other side. So that takes us to a conversation that healthcare and explicitly, I can say the hospital sector struggled with justice. But that is a conversation that we need to be able to have at such a time as now. And how do you do justice work, and how is equity on that roadmap or that pathway, and what is the role of advocacy in getting us to the point where bigotry can be made upright? Because that's when you can have evenly distributed food for all different types of communities and populations. I'm partial to this definition. Yes, I'm a fan of Dr. Pamela Jones. And so, we frequently talk about health equity in various different ways. But I like the word assurance in there. And especially in the context of advocacy and the ways that we were helping community to understand what assurance looks like so that they could advocate for their own best interests. It's like at one point during the pandemic, the government sent you tests. They mailed them to your house. That's a story. At one point during the pandemic, you were able to get a test for COVID free of charge. That's assurance. Okay? And so how do we create assurance at baseline, but can we and will we be able to create the context for assurance in what we find ourselves in today, akin to guerrilla warfare? Just extrapolating and taking this a little bit further, when you're advocating for historically excluded groups like Black and African American people, among others, Native and Indigenous populations, Latino folks, too often the conversation is uni or bi-dimensional, right? And we talk a lot about the quality of care and access to care, and rightfully so. In the healthcare, especially in the hospital sector space, we talk more about social needs than we do about social or structural determinants. Hospitals, and especially the broader organized healthcare space, is still challenged around what its role is, what is the accountability of an institution to create the conditions or the environment, right, that contributes to the exposure, that contributes to the opportunities that shape a person's health and life outcomes. I recall back from my hospital days, we were going in, right, on a project, a development project, with the state. We got some funding. Funding came first through HUD in our state in New Jersey, where I hail from, and we were going in on a affordable housing development, right? Mixed use, residential and some community space. With the conversation would ultimately become commercial space. What does that look like? Hospital has a vested interest in it because it's in its catchment area, right? We have patients or people who are frequenting the emergency department because they didn't have a usual source of care because of the social needs in their lives, right? So this is the same work of moving a population back from the cliff, right? So that's the part that I'm saying that we find we were struggling at baseline. And we were having a more sophisticated conversation, if you will, around access and quality. We were able to ultimately discuss and talk about why is it that Black and African American communities bear the disproportionate burden of the disparities that they do across multiple disease states and clinical conditions. Right? We were able to have that very frank and transparent conversation, a lot of it during the pandemic because of the multiple events that were unfolding right before our eyes, the public murder of George Floyd, COVID decimating all Americans, but certain groups worse than others. We were actually starting to do better at talking about the differences in the access to care and the differences in the quality of care. And then the election happened. Right? And then the election happened. So where before it was difficult to talk about moving populations back away from the cliff, whereas one time when I showed this, a young man said, "Why is it even the cliff? That's the problem to begin with." I said, "No, son." I know the age I can now say son. That's the conversation that I don't think I can get into in these 15 minutes that particular platform has given me. But that's what we find ourselves faced with. And we were doing some work in Los Angeles not too long ago, part of a project that I will share with you as an example of where we're going in this talk. And, we were talking with one of the panelists, and she said, the political determinants of health, those are the massive determinants. As if to say, those are the big dog of determinants. Right? And helping our communities understand, and our parents in public health, and probably perhaps many of you across this room, we talk about civic health, right? We talk about, interaction with civic institutions, civic governance, interconnectedness among community and residents, how engaged people are in the processes of civic governance. And so while we were talking a lot about civic health, now the big brother, the political determinants of health. In the span of just 24 hours, what's happened? You all know what's happened in the span of 24 hours, right? Every day there seems to be another bomb that's dropped, another catastrophe. I went from being a part of an organization that had a constant seat at the table with government decision makers to being a part of an organization that says we're totally walled out through one branch of government. So how do we then advocate in a way that could have some measurable impact? Right? What are the strategies, if you will, and sometimes the tactics that we have to consider in order to have a measurable impact through the systems or through the institutions that you previously would have been able to do? Is there any opportunity in the legislative branch? Over the past couple of weeks, I can tell you there has been a lot of back and forth with certain representatives of the Empower Party in Congress to see if we could, lessen the blow of the proposed Medicaid cuts, right? There have been a lot of conversations about uplifting collective needs. There have been a lot of conversations about understanding the root of disparities through a geographic lens, right? So we can widen the conversation to impact perhaps even some of the voters who voted in favor of the current administration, so that others in the legislative branch would understand just how disastrous the impact could be. But that story's still waiting to be told. Right? So that gets into some of the specifics of what we're doing in the NAACP. I've been in this role for a little over a year. I told you I like to get into some good trouble. And the gift of the role is to say, and I want you to hear this because I think this is something all of us can adapt and, as a part of a cross-pollination process. The gift of the role is to say, how do we multiply the power? How do we multiply the voices? How do we multiply the expertise of our member leaders and activists across the United States to show up in different arenas so that we can achieve a collective goal? right? And so sitting in an organization that has this national office, but the muscle and the power of the NAACP are the 2,000 plus branches across the United States. The muscle and the power are the health leads. The muscle and the power are the state conference presidents. And there's a varying skill set, if you will, within that. There are some from a medical or a public health healthcare background, and then some is just the granny on the block who lived there all of her life and knows more than most other people and knows how to get things done. So I start with that premise and to say, how do you harness that type of power to have what? A measurable impact. And so you'll see the pillars of the center, and I will talk a little bit more deeply about this so you can see where we're advocating, where we're having some successes, and where we're at impacts. And a book I'm reading now, Grown Women's Talk by Dr. Sharon Malone, she says the line in that book that we of us live, we hope to have more victories than losses. We hope to have more victories than losses. So we have equitable access to quality health care and equitable health outcomes. A lot of the work of the center and of the NAACP is in that pillar, especially around access, right? So thinking through how, and go back to the clip of good health analogy that I shared, right? Access to life opportunities, access to care, and access to quality care, right? And so a lot of investment around Medicaid expansion, a lot of investment around getting people enrolled in the ACA. I remember in the early days of my tenure in this position when we thought we had an opportunity to get Medicaid expansion across the line in Mississippi. And the flurry of activity that unfolded very quickly in an agile way when we thought that there was a meeting of the opportunities from the different partisan sides of a coin to say this is good for all Mississippians. And what are the arguments that we should make? What are the case studies that we should look at? Looking at some of their other Southern peers who had Medicaid expansion, some with a work requirement, and some just a blanket Medicaid expansion, and thinking through how do we use that information and what are the tools that we are using to achieve that. We got close, but not across the line, and then this administration happened, right? And that second pillar, equitable food access, where do you begin? A lot of this work was a mixture of a policy conversation, policy innovation, versus food literacy and efficacy conversation, right? So community level, policymaker level, and where do the two of those meet in between? And right now, I spend some time on that today because you're going to see a fulcrum. You're going to see a fulcrum in the federal government, especially in the health space. There is going to be a focus around food that is going to be at odds with access. Because the language, you know where I'm going, or the posture of the focus around food is antithetical to the devastation that's being caused by the ripping away of access. And when you get deep in that conversation about food, there are SNAP benefits that are also on the table. So you can't really be having an informed dialogue around food if you're not having a policy angle to match. And the others I'll talk about as I go along. I'll come back to that. But what's the secret sauce at the NAACP? This is the secret sauce, not a secret. Right? And so the NAACP employs a 7-point advocacy model. That's not rocket science. It's just how you put these things together. It's just where do you focus more energy at a time, perhaps where do you focus more investment, where are more of your intentional strategies, what's your diversification across this, right? So mobilization, mobilization, mobilization. I remember when I was considering taking on this role, someone who, like, Dr. Smith, but she's not in the AACP universe, right? And so tell me your thoughts about how you would mobilize community, because that's their expertise. And I think that is something that we in healthcare, we, especially in public health, we need to be explicitly better at. Explicitly. So that community, and it matters whether or not you have an individualized direct patient care practice or a population approach to your direct patient care practice. Because otherwise healthcare is happening too in a more passive fashion to people, except instead of healthcare happening as a part of a partnership, a shared decision making. And you have this compliance trope that's at competition with how a person goes about to otherwise make their decisions, right? So we need to become better at mobilizing the community and understanding what are the factors that activate people around certain decision points. Research. This is so important right now. We talk daily about the erasure of data. We talk daily about data that is vanishing when we finally thought we got to a point in population health and just more broadly of talking about data stratification, right? Data democracy, all the terms that were being bandied about. We need to be able to understand what is happening in subpopulations. We need to be able to understand people across the intersectionality of their identity. We need to be able to understand where there might be an opportunity to convert a disparity into a strength and an asset. And then it's like the floor was pulled out from underneath from data and data was hid. Because if you can't quantify or qualify the issue or the problem, then it's not a problem, right? If you can't quantify it or qualify it, then you're not accountable to do anything about it. It's just an amorphous blob. So there has to be a vigilance. And hear me, there has to be a vigilance around creating and building and protecting data. But data can't just live with us. Data has to be in the hands of community. Community has to have a literacy around data. Community has to have an advocacy around data. Otherwise, data is just dead. I used to say during the pandemic, I lost my father. The anniversary is coming up very soon, April 13, 2020. My father had lived through everything. My father had chronic AIDS. My father had emphysema. My father developed lymphoma. He was just the man that nothing could kill. And then he got COVID. Jim Crow couldn't even kill him. Then he got COVID. Listen to that. Right? And I remember when I decided that I was going to volunteer for the vaccine trial. And I'll never forget, I was sitting on my sofa, and I lived with my parents in Jersey at the time, and I said, I'm going to do this. I said it out loud to myself, I'm going to do that. And I remember my family saying, why are you going to do that? Why do you need to do that? You're taking this boo stuff too far. I'm boo in my family. The eventual. The baby by almost 10 years from everybody else. But I remember saying to him, when I found out that I was actually in the arm, where I received the actual vaccine, I said, Daddy, I've become a data point. I looked at myself, become a data point. My father was a research scientist. He started at Bell Labs cutting grass. The famous Bell Labs that didn't call waiting, three-way call, caller ID. My father advocated for it and hired Dr. Shirley, who was responsible for those discoveries. This man didn't go to college, right? So he was always talking about, follow the data, follow the data. He used to plot and chart out his details. Follow the data, boo. I was like, I've become a data point. So if data doesn't rest in community, and community doesn't understand the power of data, then data's dead. Storytelling. We have to become better storytellers. Point blank. As physicians, we are not the best storytellers. Sometimes it's like we've lost our humanity. And especially in times like these, we need to own our humanity. I would make people uncomfortable at times by how many stories I would tell. And, I always was like, look, I have explicit permission, but I remember My father did not disclose his status to us for about 10 years, but I was also in medical school, so I started to figure some stuff out. And I remember when he finally, just one day, he just openly shared what was going on. We were in the hospital room. He was having a bout with his emphysema. He was getting these experimental valves placed in, IV valves. And he was, she just said it. And I had a suspicion for a while, but he had not shared that publicly. And I remember he got sick right before the pandemic, and he had a rupture of an aneurysm in his lung, and he was in a regular patient floor, and he got rushed to an ICU floor, and the ICU doctor said, "Watch out, here comes HIV!" As he was being wheeled into the ICU, and within a couple of days he couldn't breathe, he was intubated. But he was so enraged in that moment that he said, "I have to call my son. My brother's the bishop." And he said, "He has to come here now." 2 or 3 in the morning. He said, "This man he's just disrespecting me, so it's not possible for him to take care of me. Come here, I don't want to die. Something is about to happen." And he gave me permission. He said, "Boo, when I'm gone, you tell my story. You tell my story to whoever will listen." And we have to become better storytellers, especially now, right? And you're familiar with advocate, you're familiar with litigate, you're familiar with convene and train, but I just wanted to spend some time on those first 3. What does advocacy require? Power. Let that sit. Advocacy requires power. And if advocacy requires power, then it also requires upset or disruption. What we're seeing right now, especially play out in the federal government, on both the legislative and the executive side, and there is actually a fight generated to loom between the executive and the judicial, but what we're seeing play out, that's not disruption, that's annihilation. Disruption can be healthy, although it can undo the status quo. Annihilation is like obliteration of the semblance of an opportunity to bring change. If you're going to have upset or disruption, then what's the upset around and what are you disrupting? Assets or resources. I've had so many conversations, whether with nonprofits, whether in academia, whether in our own organization, whether with providers, but my funding, if I don't have the funding to do this body of work anymore, how do we drive the change that we want to drive? Also through a more expansive understanding of what is an asset, right? And the rest of it, I believe it's self-explanatory. But the first 3, even the first 4, I would say, we have to get better at. I remember Soledad O'Brien, it probably was 2017 or 2018, came to our conference for preventive medicine, and she said, "You all are horrible at explaining." We're all like, "You all are horrible at explaining what public health is, what population health is, and we don't know what the social determinants of health are. What is that? Use better language." I'm like, "Okay." And so this is where I really want to begin to rest and wrap. And so I told you I work with OD, Organizational Development Consultants, and we're in this type of time on steroids. VUCA, it's pronounced both ways. Volatility, uncertainty, complexity, and ambiguity, right? So when you're in a volatile environment, it demands that you react quickly. You get stunned because you're always reacting, or there's an opportunity to react to so much. The unpredictability of it in and of itself is depleting. The uncertainty wants you to make an action or to arrive at a decision sooner, or otherwise you would have called it premature, but sooner than you feel comfortable making it. There are so many interdependencies in the environment. It is actually a skill to be able to find them, to be able to make sense of them, and to be able to deploy them in a way that it can be advantageous to your goal. Then, the ambiguity, what that is. But the challenge is to convert the volatility to vision, the uncertainty to understanding, the complexity to clarity, and the ambiguity to agility. I don't have those answers, but we can create those solutions. You hear the difference in what I just said. I don't have those answers, but we can create those solutions. And those solutions, sometimes are going to be temporal in nature, because what might work for what the type of environment we find ourselves in on day 1 may not work for day 3. But we've got to be willing to agree that we're going to have to be agile, and we have to be able to communicate that there are certain unknowns that we can't even fathom, but we have to find a way to describe what they are so that we can get some type of mobilization around certain group actions or behaviors following. So what's happening in my work? What can I say safely? So what you see highlighted, because I talk about this a lot, Medicaid defense. We're all talking about the Medicaid defense. I see increasingly opportunities for untraditional allies and partners, because Medicaid touches everything. Stop talking about it as an issue only rooted in poverty. Medicaid touches everyone, okay? It touches our senior population. It touches the beginning of life. It touches, so many of us are challenged economically because of what's happening in our economy. And so increasingly, we are looking for collaboration with people who might not be natural allies, but will be impacted the same. Protecting the ACA is also very much the same, with a little bit of a different nuance, right? And so I haven't found a change in my funders, but I have found more so a change in how funders are approaching issues in my healthy people, healthy communities, and health and health policies, my biggest bucket, right, that I could drive the Mack truck through. Meaning specifically like something around ACE, which I'll show you here. And what that means is I'm in a space where I partner with pharma. And so while we have certain sponsors or funders who are very still much staying the course, those are multinationals. Those are multinationals that live under a different set of rules or laws in different environments, so they can't totally advocate in the American market. That's the frankness of it, okay? And then you have others who are doing the language and the frame shift, health equity to health solutions, right? Opportunity work instead of access work, or instead of equity work. And I say that to say we will need, in the healthcare and the hospital space, intentionally need to think about how we diversify funding. And a place to lean into, and that I've seen some hope around, is philanthropy. Robert Wood Johnson Foundation was recently at their convening and talk about this publicly. We are one of their ESJR cohorts. And, the existential question in the room is, for those who are funded through the RWJF, through a cohort like this, but are also at risk of losing their funding for the same work from a government funder, the same work. One funder says, I will fund you to do, complicates their funding portfolio, if you will, from an aspect of a different funder. Does that mean that people would leave funding on the table? People are actually beginning to discuss that. Will people leave funding on the table because it might make them a threat? And then that would engender further attacks from a different level. I can tell you what has flexed differently in our approach, as I begin to close, is that we are doing more population-specific approaches. So what is working around a Mississippi or Alabama might be a different strategy where we have, let's say, more advocacy friendlies in different branches of governments in another state. It doesn't mean that our priorities have shifted. It just means that our priorities are hyper-local. And that we have to have the ability to flex those priorities. And then this last one, I haven't experienced it personally, but the NAACP has become an intermediary in ways that it had not been in the past. So I say that to give you an example of where there be opportunities where people are losing funding in one sector or space for intermediaries to arise, and for those intermediaries to then be able to take on dollars because it can, and then to be able to disperse those dollars to those who are in need. So I take you back here just to pause and for you to deliberately think, because somehow we have to link health equity to the human experience. Because this is where the work was moving about 3 years ago, and that the work is going to increasingly go into this space. Human, 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 human. And thinking through different lenses, thinking through geography. There's a lot of talk about what's happening in rural spaces, rural hospitals, rural health, and rightfully so. Black folks are in rural spaces. Historically excluded groups are in rural spaces. Thinking more through a deliberate lens around socioeconomic status. Look, I'm never going to tell you that racism is something we can neutralize and only talk about these other bubbles around this circle. But I am going to tell you the strategy, or how you might have to lean in different conversations so that you can still achieve the same bottom line. And these are ways that there is work, protected work in space. Lived experience. This is probably the one that requires the most creativity and innovation. Lived experiences that contribute to certain exposures. Think occupational, think living arrangements, right? And those lived experiences have a set of disparities that are attached to them. And those lived experiences may be duplicable or replicable, I should say, across multiple populations, but different levels of intensity. And finally, agility, adaptability, and authenticity. That's the triple threat. So if you're converting volatility to vision, uncertainty to unity, complexity to clarity, ambiguity to agility, you really can change that A in multiple different paradigms and settings. We've got to get more creative. We heard this when we were in kindergarten. And then it kind of got pushed out of us because then we were told to put on our thinking cap. And we learned that thinking might have been different than creativity, right? But creativity begets decisions, decisions begets problem solving begets adaptability, agility, and authenticity begets communication. Thank you.
I don't know if we're going to use this iPad now, but we're going to moderate some questions. So we'll take some questions in the audience. I don't know who has the mic.
The mic. Any questions?
Just raise your hand.
I'm Sharon.
No.
We can call Sharon.
If you stand up. Yes, ma'am. There you go.
Thank you for your amazing presentation. And it's when I first worked off of years ago, but I was at that time. In your position, I know it's just been a year or so. If you could wave a magic wand, if you will, and say something for all of us to go do tomorrow, a phone call, an email, coalescing, or a meeting, what would your suggestion, what would your recommendation, or your instruction be?
Yeah, excellent. I don't think many physicians engage with political decision makers in the ways that they should or they need to. And what I mean by that, I first started to say this during my residency, the political physician. And that's not P as in party, but that's P as in, political determinants of health. I don't think we understand the power of our voices showing up in elected officials' offices and describing situations in both a plain-spoken language and form language. The difference of that and helping them to meet the two. And this allows people to be able to say, okay, I understand how I need to perhaps argue differently for the certain positions that I'm doing. That's one thing, right? Too many physicians at times, literally, they'll say, I don't get into the politics. You've got to get into it right now, or people are going to continue to die at alarming rates because of the type of craziness that's happening at multiple levels in the political structure and apparatus is mind-blowing. That's one thing. Two, get in concert with the communities that you serve. And what I mean by get in concert with the communities that you serve is understand the issues through the lens of community. Understand the issue through the lens of the person. I used to always talk about this a lot in Newark. I mean, I got some New Jerseyans in the room and other places. I would ask people, how many school board meetings have you been to? How many city council meetings have you gone to? Have you ever been to a zoning commission meeting? That's where all the decisions are being made that impact a lot of those determinants and the outcomes on your lives. So we have to sit across the table from community and really elevate their community expertise to say how they are experiencing life in that community, and then think about where are the opportunities for partnership. So I'll leave you those two.
Thank you.
Let's just go down the line here.
You first.
Lou and then Dr. O'Gay.
Thank you for your presentation and your advocacy. I'm doing some advocacy work with ODR and several medical societies. And can you suggest some resources to help us educate patients about the connection between their vote and their health, and also encouraging them to register and to vote?
Okay, so come to me after this talk, because I am in perimenopause, so I can't remember things like I used to. I'm just going to down the table. I'm almost 50. But there is this website that I came across about in the past 3 to 4 months, and I screamed about it to everybody in the NAACP. And it is a website that allows the user to, it's the best that I've seen, understand the links between voting disparities and health disparities. It breaks it down from a legislative angle. It breaks it down from a structural determinant angle, meaning that many of the same barriers to the vote are also the barriers that contribute to poor health and outcome, right? And it does it on a state-by-state basis. That's one of the best tools I've ever come across. Two, we have to get better at converting civic health into digestible bits that community can understand. And so, like I was saying last night, I did a keynote for a township address, and I said my mom used to always drive me to a suburban neighborhood to go to the grocery store. Because she said, Chris, the meat is better there. They have better cuts. So I go there to get my meat there, right? And to help my mother understand, well, yes, it's okay for you to drive there. What if you showed up in zoning? What if you showed up with your local health department, right? What if you were able to advocate for issues with decision makers that are going to impact your lived experience? That's what we have to do better at. And I love the Vote ER. We put a voter registration kiosk in my ED, and I remember one of the executives says, well, should we be doing this? We're not supposed to get into partisan politics. We have to separate vote from partisan. Right? Increasingly, vote has become a partisan term. When vote is a behavior, I tell people it's a health behavior. Voting is a health behavior, right? So those are just some quick emojis. I have to show it to you because I can't remember the full URL. But it's health democracy, basically. But I'll show it to you. I keep it open on my tab.
Dr. O'Gay.
So you can share that with all of us because we have here. So some of us over here, you didn't really originally get a lot of hands up because your presentation was so deep, like just to digest it. and we totally appreciate it. We totally appreciate it. Because some of us who are great here, we like you the future. So we're totally happy. But we need to know from a perspective, and I'm not sure if you said what UCA, B-U-C-A, I missed it, just a minute. And then secondarily is NMA partnering with NAACP, because the issue becomes Alexandria Ocasio-Cortez and Bernie Sanders are going state by state rallying people. And of course, that's not in the media. Okay, folks don't know that. And so we have to go to the street. We have to connect.
Say it.
We have to connect all of our organizations.
Say it.
Y'all leading that? Who's leading that?
We won't be leaning on
All right, good.
people in this room. There's a lot of organizations.
Okay, that's what we want to know. Who's
Okay,
leading that?
so this is what it is. I just wanted to put it up visually.
Oh, thank
Some of
you.
us are visual learners. Volatility, uncertainty, complexity, and ambiguity, right? So that's the type of environment that we find. I mean, this it doesn't just happen now. This is what the environment is. And that's the environment that we find ourselves in. And the goal is to convert it to vision, understanding, clarity, and agility. And we make sure everybody gets this.
Excellent, thank you very much.
Okay? And then, yes, we are going to become more intentional. We got to show up where the people are hurting. We got to show up where the people are angry. We got to show up where the people may be apathetic or even ambivalent. And in an organization like mine that has approximately upwards of 2,600 branches, but they all don't have the same capacity, they all are not engaged in the same issues, we're thinking through how do we become more community first, right? How am I not just in national office, but I'm actually showing up in these places? And increasingly, my partnerships put me in different geographies. I have one partnership that puts me in 15 places. I have another partnership that puts me in 9 places. I have a budding partnership that's going to put me in 4 places, right? So looking at issues through a very hyper-local lens, because then you get better mobilization, you get truer advocacy, and that's when you begin to create equity.
Thank you. Thank you. Dr. Perez.
And to follow up past President Ortiz' comments, Dr. Montague Cobb was also president of the NAACP. So the connection has been there. Almost from
Point heard, point taken.
Someone over here is ready to raise their hand.
I just wanted to say, we also need to mobilize at our state houses quickly.
Yes.
And the example of IVF,
Yes.
the Alabama Supreme Court was the one who came up with just banning IVF.
Yes.
Within that week, there were hundreds of white women
Yes.
who came to the state house. And I remember a legislative aide said, boy, I wish we could mobilize our community like that in numbers, because it got their attention. And of course, you can see the reverse of that whole policy now because of that pressure
Yes.
from the community.
And can I just say something about that? And that's increasingly why we're talking about this local approach. Even now, where we lost a national opportunity around the menthol ban, right? We pivoted too slowly in the NAACP. We're having this conversation, but we're now showing up where there's an active piece of legislation, let's say, local ordinance versus legislation that's working its way through state legislatures. We just had SLAW, State Legislative Advocacy Week, where we focus and drill down on what's happening through a state-specific lens. And that's different from our federal advocacy days. And that's really informed by people on the ground in those states. And then we come along and we ensure they have the skill set to be able to meet the moment in the ways that they want to.
I think we have quite time for one more question. Is there one over here? One other question? If not, okay. Let me thank Dr. Pernell. Thank you very much. That was and turn it back over to you, Dr. Kane, or to